Welcome to the deep dive. Um, if you are tuning in today, there is a very good chance you are a nursing student.
Yeah, probably looking right down the barrel of your week 7 material.
Exactly. You're probably staring at Chapter 27, which is Assessment and Management of Patients with Hypertension.
It's a heavy one.
It really is. I remember looking at chapters like that back in the day. Just pages upon pages of these cascading physiological pathways.
Oh yeah, the endless charts of medication classes.
Right, and all those rigid diagnostic parameters. You just sit there thinking it's an impossible mountain of memorization.
It feels completely overwhelming at first.
It does. So if you are feeling that exact same sense of being overwhelmed right now, just take a deep breath. You are in the right place. Okay, let's unpack this.
Let's do it.
Our mission today is to take that really dense, intimidating textbook chapter and translate it into actual practical clinical wisdom.
Because that is what you'll actually use on the floor. Our goal today is to completely demystify Chapter 27. We don't want to just memorize numbers. We want to understand the why behind blood pressure management, the nuances of patient assessment, and most importantly, the critical role nurses play in saving lives from what we call the silent killer.
Yeah, that is the perfect way to frame our goals today. Let's get into the actual landscape of hypertension, or HTN as you'll see it charted.
It is the single most common chronic disease among adults globally.
Wow.
Yeah, when you look at the epidemiological data, it's cited as a leading risk factor for premature death, disability, just overall disease burden worldwide.
Because it feeds into everything else, right?
Exactly. It's this insidious pipeline that directly feeds into cardiovascular disease, stroke, and chronic kidney disease.
So why should a nursing student care so deeply about this specific pathology? Aside from passing a test, I mean.
Because the research here is phenomenal. Studies actually show that nurse-led hypertension management demonstrates significantly greater rates of blood pressure control compared to non-nurse-led efforts.
Yeah, it is an amazing statistic.
It really is. It puts the listener, you, the nursing student, right at the absolute front line of combating this massive global burden.
That completely shifts the perspective. You aren't just a passive observer in a clinic. You are training to be the primary driver of successful patient outcomes.
You are the front line.
So to operate on that front line, we really need to look at the new rule book, because the medical guidelines for diagnosing hypertension underwent a pretty seismic shift not too long ago.
They absolutely did. Medicine is always evolving.
Right. So for a long time, the community relied on the older JNC7 and JNC8 guidelines. But Chapter 27 highlights a major turning point.
The 2017 guidelines.
Yes, when the American College of Cardiology and the American Heart Association released their updated 2017 guidelines, they essentially redrew the map.
They redrew it. And the reason why the ACC and AHA changed those parameters is such a fascinating look into human psychology.
How so?
Well, under the older guidelines, we had a category called pre-hypertension.
Right, I remember that term.
But there was a major flaw with that terminology. When a patient sits in an exam room and hears a provider say they have pre-hypertension, their brain latches onto the prefix.
The word pre.
Exactly. They think, oh, I'm in a safe zone. I'm just approaching a disease, but I don't actually have it yet.
They don't take it seriously.
Right. It cultivates this false sense of security, which leads to them delaying crucial lifestyle changes.
Oh, that makes sense.
So to eliminate that complacency, the 2017 guidelines completely scrapped that term. They renamed it elevated blood pressure.
Wow, just changing the name changes the perception.
What's fascinating here is that this wasn't just some semantic game. The committee wanted to explicitly highlight that cardiovascular risk and vascular damage are actively occurring at those levels, way earlier than we traditionally thought.
Language really does dictate patient behavior. Calling it elevated sounds like an active problem that needs an active solution. So let's get into the hard numbers for those ACC and AHA 2017 guidelines, because this is the absolute bedrock of what you need to know for your Week 7 exam and your clinical practice.
And the parameters are noticeably tighter now.
They really are. So the definition of normal blood pressure is now strictly defined as a systolic pressure, which is that top number when the heart contracts of less than 120.
Right.
Combined with the diastolic pressure, the bottom number when the heart is resting of less than 80. And the vital word there is and. Less than 120 and less than 80.
Both of those conditions absolutely must be met to be considered normal.
Okay, so moving up the scale, we reach that newly designated elevated category we just talked about.
This one is defined by a systolic reading between 120 and 129. but it's paired with a diastolic reading that still remains less than 80.
It's a really narrow window.
Very narrow. If that systolic pressure creeps up just 2 or 3 points into the low 120s, but the diastolic is completely normal, they have officially crossed out of the normal range.
Okay, then we cross the actual clinical threshold into real hypertension, stage 1 hypertension.
Right, so stage 1 is defined as a systolic pressure ranging from 130 to 139, or a diastolic pressure between 80 and 89.
Notice how the conjunction flips there, from and to or.
That's a huge distinction for students to catch. If either the top number hits 130 or the bottom number hits 80, the patient is in stage 1.
And finally, stage 2 hypertension. This is a systolic of 140 or higher, or a diastolic of 90 or higher.
And a good clinical rule of thumb here, if a patient presents with a systolic in the stage 2 range, but a diastolic in the stage 1 range, what do?
You always classify them by their highest category.
Exactly right. Always go with the highest category.
So if we connect this to the bigger epidemiological picture, tightening those diagnostic parameters must have created a massive shockwave.
It was immediate. When the old JNC guidelines were active, roughly 32% of U.S. adults were classified as hypertensive.
Okay.
The moment the ACC and AHA published the 2017 guidelines, simply by lowering that threshold down to 130 over 80, the prevalence skyrocketed to 46%.
That is insane.
We basically woke up one morning and nearly half the adult population in the country had a hypertension diagnosis.
That sounds like an instant public health crisis.
Nah.
I mean, did clinics suddenly have to prescribe pills to an extra 14% of the population overnight?
No, and that is a really common misconception. The primary clinical benefit of redefining the guidelines was not to just throw pills at the problem immediately.
What was the goal then?
The goal was to drastically amplify the emphasis on early lifestyle interventions.
Ah, catching it earlier.
Right. By catching patients when their systolic hits 130 instead of waiting for 140 nurses, gain this crucial window of opportunity to implement dietary and behavioral changes before the vascular damage requires lifelong medication.
That makes total sense. Looking at the sheer volume of people affected, though, the textbook presents some statistics regarding awareness that are genuinely alarming.
The awareness gap is huge.
Out of all the adults currently living with hypertension, an estimated 35.3% don't even know they have it. Over a third of the population is just walking around completely oblivious.
And even among those who do have a formal diagnosis, approximately 45.4% do not have it under control.
Tens of millions of people sustaining daily unchecked damage.
The scope is immense, and as a nurse, you will quickly see that this burden does not fall equally across all demographics.
Right, there are some profound demographic disparities.
Very profound, driven by genetics, environment, and social determinants of health. For example, the prevalence of hypertension among the African-American population is among the highest recorded anywhere in the world.
The textbook notes current estimates place it at 58.6% for African-American men and 56% for African-American women.
It's staggering. And they statistically develop the disease at significantly younger ages and suffer higher rates of target organ damage compared to Caucasian populations.
The text also points out heavy socioeconomic factors. Adults in higher socioeconomic brackets generally maintain much better blood pressure control.
Which is logical when you consider the barriers.
Yeah.
Lower income patients face a lack of access to consistent primary care.
Yeah, and the high cost of fresh low-sodium foods versus cheap processed foods.
Exactly. Plus the chronic physiological stress associated with economic instability.
And then, of course, there is the unavoidable factor of age.
Age is the great equalizer. By the time the adult population reaches 75 years of age, hypertension affects 80% of men and 85.6% of women.
Your future patient panels as a nurse are going to be heavily populated by this demographic.
Which makes gerontologic considerations a daily reality on the floor.
Since we are visualizing the patient population, let's zoom in on the actual physiological environment inside those patients. Let's look at the mechanics of pressure.
The pathophysiology.
Right. Whenever I try to conceptualize blood pressure, my mind immediately goes to a plumbing analogy. The cardiovascular system is essentially a closed loop of pipes and a central pump.
It's a perfect way to visualize it.
Blood pressure itself is the product of a specific physiological equation. Cardiac output multiplied by peripheral resistance.
Cardiac output being the volume of fluid the heart is pushing into the system every minute.
And peripheral resistance is the amount of friction or constriction within those pipes, the blood vessels. So to develop hypertension, there must be an increase in either the volume of fluid being pumped, a narrowing of the pipes, or a combination of both.
If we connect this to the bigger picture, Clinical medicine divides hypertension into two major classifications based on why that system malfunctions: primary and secondary.
Let's start with primary.
Primary hypertension, also called essential hypertension, accounts for the overwhelming majority of diagnoses, between 90 and 95% of all cases.
And the defining characteristic there is that there is no single identifiable medical cause, right?
Correct. You can't point to one specific thing and say that is the singular reason the pressure is high. It is a perfect storm of multifactorial interactions.
The text mentions genetics playing a role, but it's not the whole story.
Researchers have mapped out over 1,000 different genetic variants associated with blood pressure regulation. But if you combine the effects of all 1,000 of those variants, they only account for about 6% of the variance in blood pressure.
Wow, so DNA isn't the sole culprit at all.
Not at all. It is the collision of those underlying genetics with behavioral, social, and environmental risks: obesity, high-sodium diets, sedentary lifestyles, and chronic stress.
That leaves secondary hypertension, which makes up the remaining 5 to 10% of cases.
In these scenarios, the high blood pressure is a direct symptom of a specific identifiable underlying pathology.
Like what?
Common culprits include chronic kidney disease, where the filtration system is failing, endocrine disorders like Cushing syndrome or a pheochromocytoma.
A pheochromocytoma is that rare adrenal tumor, right?
Exactly. It pumps out massive amounts of adrenaline, which just clamps those blood vessels down. Other causes are obstructive sleep apnea preeclampsia in pregnant patients, and even the chronic use of medications like NSAIDs or substance abuse.
So if you were a nurse conducting an intake assessment, what are the red flags that should make you suspect secondary hypertension instead of primary?
You look closely at the timeline and the patient's age. If you have a patient who is under 30 years old suddenly presenting with new onset hypertension, that is highly suspicious.
Because primary usually develops gradually over decades.
Right. Similarly, if a middle-aged patient with historically normal blood pressure suddenly develops severe hypertension out of nowhere, or an abrupt onset in anyone, really.
What about patients taking multiple medications?
If a patient's blood pressure remains stubbornly high despite being compliant with 3 or more different classes of antihypertensive medications, that resistant hypertension screams that a secondary cause might be driving the pathology.
Because simply adding a fourth blood pressure pill isn't going to cure a hidden adrenal tumor.
Exactly. Or fix their sleep apnea. You have to treat the root cause.
Let's look at the actual bodily systems that drive up either cardiac output or peripheral resistance.
Yeah.
What are the physiologic culprits here?
Well, it's incredibly multifactorial. First, you frequently see overactivity of the sympathetic nervous system.
The fight or flight response.
Right. When a patient is under chronic stress, their body remains in a low-grade fight-or-flight state, causing continuous vasoconstriction and an elevated heart rate.
Then you have defects in renal sodium excretion.
The kidneys inappropriately reabsorb sodium and water back into the bloodstream instead of excreting it. That directly increases the overall fluid volume inside the pipes.
Then there is the RAAS pathway,
Hmm.
the renin-angiotensin-aldosterone system.
This is a massive player. We will dive deep into RAAS when we discuss pharmacology later. But essentially, an overactive RAAS pathway triggers both massive vasoconstriction and extreme fluid retention.
The text also highlights insulin resistance as a common denominator.
Yes, this is the physiological bridge that connects hypertension with type 2 diabetes and obesity.
And recently, researchers have been focusing heavily on the immune response and vascular inflammation.
They've noted that immune cells can actually infiltrate the blood vessel walls, causing chronic vascular inflammation. This leads to endothelial dysfunction, which prevents the vessels from dilating properly.
The complexity of all those overlapping systems is wild. And on top of all that chemistry, we have to account for the structural changes that occur simply through the aging process.
Gerontologic considerations are huge here. As the decades pass, the actual architecture of the blood vessels deteriorates.
The textbook mentions the fragmentation of elastin.
Right. The elastin fibers in the arterial walls begin to break down, and rigid collagen deposits take their place. The major arteries, particularly the aorta, lose their elasticity. They become stiff, unyielding pipes.
So because they can't stretch to absorb the forceful wave of blood coming from the heart, the pressure inside spikes dramatically during every single heartbeat.
That structural stiffening causes both systolic and diastolic pressures to rise steadily until about the 6th decade of life.
But then a distinct pattern emerges, right?
Yes. After age 60, the diastolic pressure slowly begins to drop while the systolic pressure continues its upward trajectory. This results in what we call isolated systolic hypertension.
Which is characterized by a systolic reading greater than 140, alongside a diastolic reading of less than 80.
That is the predominant form of hypertension in older adults. And clinical trials have definitively proven that treating and lowering this isolated systolic pressure drastically reduces adverse cardiovascular events.
Which transitions us perfectly into Section 3, the art and science of the assessment.
The silent killer.
Throughout the medical community, hypertension is universally known as the silent killer. It is imperative to communicate to your patients that hypertension almost never presents with symptoms.
A patient can walk into a clinic with a blood pressure of 180 over 110, feeling completely energetic and normal.
By the time they actually feel symptoms like severe headaches, dizziness, or vision changes, the disease has usually progressed to a very dangerous stage.
We refer to that progression clinically as target organ damage.
Imagine a high-powered pressure washer constantly blasting against the most delicate microscopic tissues of the body, 24 hours a day, year after year.
That imagery is spot on. Let's examine the specific organs that bear the brunt of this trauma. We typically start by looking at the eyes.
Because the retina is the only place in the body where we can directly visualize the microvasculature.
Exactly. During an ophthalmoscopic exam, you might see tiny retinal hemorrhages, fluid accumulation, or cotton wool spots.
What are cotton wool spots exactly?
They are essentially microinfarctions where the retinal tissue has died from a lack of blood flow due to the vessel damage.
Yeah.
In severe accelerating cases, the optic disc itself can swell, a condition known as papilledema.
The heart is obviously another primary victim. It's forced to pump against that immense peripheral resistance with every single beat.
Just like a skeletal muscle lifting heavy weights, the cardiac muscle responds to the increased workload by bulking up and thickening. We call this left ventricular hypertrophy, or LVH.
As a nurse performing a cardiovascular assessment, how would you detect LVH?
You might physically palpate a displaced apical impulse. Or you might hear an abnormal S4 heart sound through your stethoscope, which indicates blood being forced into a stiff, non-compliant, hypertrophied ventricle.
And over time, that thickened muscle outgrows its own blood supply, leading to angina, myocardial infarction, and ultimately heart failure.
The kidneys are equally vulnerable. The delicate filtration units, the glomeruli, are obliterated by the high pressure.
You detect this renal damage through routine lab work, right? Elevated levels of blood urea nitrogen, or BUN, and serum creatinine?
Yes, and another early indicator is microalbuminuria, which is when the damaged filters allow proteins to leak into the urine. Clinically, the patient might complain of nocturia, waking up multiple times a night to urinate because the kidneys lost their ability to concentrate urine.
Finally, we look at the brain. The constant hypertensive hammering weakens the cerebral blood vessels, making them prone to either bursting or forming microclots,
Leading to transient ischemic attacks or TIAs and catastrophic strokes.
Hearing the extent of that systemic destruction underscores why getting an accurate blood pressure reading is arguably the most important task you will perform in a clinical setting.
It's not just slapping a cuff on an arm, it is a clinical skill requiring absolute precision.
The textbook includes Chart 27.3, which lays out incredibly strict rules for taking a proper blood pressure measurement. If you bypass these steps, your resulting numbers are fundamentally flawed.
Let's run through these strict rules, starting with patient prep. The patient must abstain from smoking caffeine and exercise for a full 30 minutes prior to the reading.
That is so hard to enforce in a busy clinic, but it's vital.
They also need an empty bladder because urinary retention triggers sympathetic arousal. Then they must sit quietly for 5 uninterrupted minutes.
Feet flat on the floor, right? No crossed legs?
Right, feet flat, arms supported at heart level, and perhaps the most difficult rule, no talking.
Neither the patient nor the nurse can talk.
Just the cognitive engagement of a casual conversation can artificially spike the systolic pressure.
It is wild to think that asking a patient about their weekend could alter the numbers enough to push them from an elevated category into a stage 1 diagnosis.
It happens all the time. And beyond patient prep, the physical equipment matters just as much. Cuff size is critical.
The bladder width must equal 40% of the limb circumference, and the length should cover 80 to 100% of the arm.
If you grab a standard cuff for a much larger arm, it's too small and will generate an artificially high reading.
And if you use a large bariatric cuff on a very frail, thin arm, it will yield an artificially low reading.
You have to choose the correct tool. And even with perfect technique, a single elevated reading almost never confirms a diagnosis.
The diagnostic criteria require an average of at least 2 carefully taken readings on at least 2 separate clinical occasions.
Unless, of course, their average is greater than or equal to 160 over 100 on that first visit. Then the risk is too high to wait and you diagnose immediately.
This focus on the clinic setting brings up two fascinating phenomena detailed in the text: white coat hypertension and masked hypertension.
What's fascinating here is how deeply human psychology intertwines with the autonomic nervous system. White coat hypertension occurs when a patient's readings consistently spike, specifically in the healthcare setting.
Driven by anxiety regarding medical exams.
Right, but their readings return to completely normal baseline levels at home.
The clinical danger there is overtreatment. Prescribing potent meds to someone who has normal blood pressure 95% of the time, putting them at extreme risk for dangerous falls at home.
Exactly. The inverse of that is masked hypertension, which is arguably much more terrifying.
This is the patient whose blood pressure is a perfect 118/76 in the clinic. But the moment they return to their highly stressful job, it soars to 150/95.
Their condition remains completely hidden. They are left untreated and are at an incredibly high risk for a cardiovascular event because the healthcare team falsely assumed they were healthy.
This is why the solution is home blood pressure measurement, or HBPM, or ambulatory blood pressure measurement, where they wear a device that inflates every 30 minutes for 24 hours.
Seeing how the cardiovascular system behaves in their natural environment is absolutely essential.
Okay, assuming we have an accurate diagnosis, let's pivot to the first line of defense: lifestyle interventions.
Before the prescription pad comes out, modifying daily habits is the primary intervention.
Table 27.2 in the text breaks down these interventions and assigns concrete numbers to them, showing their expected systolic impact.
Weight reduction is incredibly impactful. You can expect roughly a 1 millimeter of mercury systolic decrease per 1 kilogram of weight loss.
So a 10-pound weight loss could mean a 4 to 5-point drop just from reducing the physical strain.
Then there is the DASH diet, dietary approaches to stop hypertension.
This is heavily researched. It focuses on 4 to 5 servings of fruits, 4 to 5 servings of vegetables, low-fat dairy, and lean proteins.
Strictly adhering to the DASH diet can lower a hypertensive patient's systolic pressure by an astounding 11 points.
We also have to manage the delicate balance of sodium and potassium. Sodium should be restricted to less than 2 grams per day.
And dietary potassium should be elevated to between 3,500 and 5,000 milligrams per day.
But there is a massive crucial clinical note here. High potassium diets must be strictly avoided in patients with chronic kidney disease.
That is a vital nursing alert. Their compromised kidneys cannot excrete the excess potassium, leading to fatal cardiac arrhythmias.
You always verify renal function labs first. The other pillars are physical activity, 90 to 150 minutes of aerobic, dynamic, and isometric resistance training a week, and moderating alcohol.
Stacking all these lifestyle changes together can sometimes exceed the efficacy of pharmacological therapy.
But when lifestyle modifications aren't enough, we escalate to the pharmacological arsenal, a deep dive into the meds.
Pharmacology can be overwhelming for students.
It really can. But don't look at Table 27-4 as just a list to memorize. Look at it as a strategic toolkit. Here's where it gets really interesting.
Let's systematically walk through the major drug classes from Table 27-4, explaining how they work and the critical nursing considerations for each.
First up, the thiazide diuretics. Medications like chlorthalidone and hydrochlorothiazide.
These target the fluid volume side of the equation. They decrease total blood volume by forcing the kidneys to excrete sodium and water.
Since you are flushing out electrolytes, your nursing assessments have to focus on lab values. You monitor for hypokalemia and hyponatremia.
And a major contraindication, they should be avoided in patients with a history of gout, as they can trigger a flare-up. Also, watch out for orthostatic hypotension in older adults.
Next are the ACE inhibitors, the ones ending in -pril, like lisinopril and captopril.
These inhibit the enzyme that converts angiotensin III to angiotensin II, stopping that massive vasoconstriction.
The nursing alerts here are infamous. First, watch for hyperkalemia. Second, the infamous ACE cough, a dry hacking cough that drives patients crazy.
Third is the rare but life-threatening angioedema, rapid swelling of the airway.
And an absolute contraindication, ACE inhibitors are strictly contraindicated in pregnancy.
If a patient develops the ACE cough, we usually switch them to the ARBs, angiotensin receptor blockers ending in -sartan, like losartan.
These block angiotensin II at the receptor site, so you get the vasodilation without the cough. But they share the pregnancy contraindication.
Finally, the calcium channel blockers, or CCBs. These prevent calcium from entering muscle cells, reducing the force of contraction and causing vasodilation.
They are split into two groups: the dihydropyridines, like amlodipine. A major nursing alert here is they can cause pedal edema, swollen feet, and ankles, which is more common in women.
The second group are the non-dihydropyridines, like diltiazem and verapamil. These also slow down the heart rate.
Because of that, they are strictly contraindicated in heart failure with reduced ejection fraction, or HFrEF. You don't want to further slow a failing pump.
And a general rule for all CCBs: never discontinue them suddenly.
Now, standard practice isn't one size fits all. Table 27-5 delves into special populations and comorbidities.
For example, African American patients without concurrent heart failure or chronic kidney disease should start with thiazides or CCBs, not ACE inhibitors or ARBs.
Because RAAS blocking medications are statistically less effective as monotherapy in this demographic.
Correct. And patients with stable CAD or HFrEF need beta blockers, like carvedilol or metoprolol succinate.
Beta blockers are second line for general hypertension, but absolutely essential first-line therapy for heart failure to protect the damaged cardiac tissue.
And for pregnancy, as we mentioned, stop ACE and ARBs immediately. Transition to methyldopa, nifedipine, or labetalol.
Which brings us to resistant hypertension, defined as blood pressure not controlled despite taking 3 or more meds from different classes, one being a diuretic, or requiring 4 or more to control it.
The primary nursing implication here is crucial. Always check adherence and finances first before assuming physiological resistance.
Are they splitting pills because they can't afford them? Did they stop taking them because of the ACE cough? You have to investigate those barriers.
Absolutely. Now, before we leave pharmacology, we need to explore a modern clinical twist found in the textbook, the COVID-19 paradox.
This involves the intricate dance between the SARS-CoV-2 virus and the RAS system.
Right, so the virus uses ACE2 cellular surface receptors to enter host cells. These are abundant in the lungs and blood vessels.
And patients taking ACE inhibitors or ARBs have an upregulation of these receptors. They grow more of them.
Initially, this terrified scientists. They feared these patients had millions of extra open doors, making them more susceptible to severe COVID-19.
But the paradox is what the virus does once inside. It downregulates or destroys the ACE2 receptor.
Under normal circumstances, the ACE2 receptor degrades dangerous inflammatory angiotensin II into a protective anti-inflammatory molecule called angiotensin 1-7.
When the virus destroys the receptors, angiotensin II builds up, causing massive inflammation and lung injury.
But the patients on ACE inhibitors, or ARBs, started with such a massive surplus of ACE2 receptors that they maintained higher levels of that protective angiotensin 1-7.
Their medication gave them a reservoir of anti-inflammatory protection.
Studies from Wuhan showed patients on these meds actually had lower mortality and lower inflammatory markers. The clinical takeaway: keep taking your ACE or ARBs during a COVID-19 infection.
That is fascinating. Let's shift focus now to the day-to-day reality of nursing care. The nursing process in action. What does this all mean for the listener on the floor?
Let's look at the adherence puzzle. The textbook highlights an incredible nursing research profile by Spikes et al. Regarding African Americans with hypertension.
They investigated what factors actually influence medication adherence, and the results were surprising.
Very surprising. Health beliefs, depressive symptoms, and social support did not correlate with adherence in this specific study.
What did correlate?
Having another comorbidity, having a second chronic disease, increased the odds of adherence by 2.63 times.
That nursing implication is profound. Patients with only hypertension might feel totally fine and be at higher risk for non-adherence than those juggling multiple visible diseases.
You have to focus your educational efforts heavily on those asymptomatic patients.
Another crucial area for education is gerontologic care. The golden rule is start low and go slow.
Target blood pressure is still less than 130/80, but nurses must obsessively monitor for orthostatic hypotension and falls.
The Quality and Safety Nursing Alert stresses teaching patients to change positions, slowly sit on the edge of the bed for a minute, and use handrails.
For general patient education, teach them about rebound hypertension. If they stop meds abruptly, their pressure can violently spike, triggering a cardiovascular event.
Ensure they pack meds in their carry-on luggage when traveling. And regarding the DASH diet, tell them it physically takes taste buds 2 to 3 months to adapt to low salt. The blandness is temporary.
Providing those practical strategies elevates your nursing practice, but sometimes the system completely destabilizes. Let's discuss hypertensive crises.
The scary extremes. We are talking about a systolic greater than 180 or a diastolic greater than 120. How do nurses distinguish between an urgency and an emergency?
This raises an important question because the numbers might look identical. It's not about the numbers, it is about the organs.
A hypertensive emergency involves definitive evidence of new or worsening target organ damage.
Encephalopathy, stroke, dissecting aortic aneurysm, acute myocardial infarction. The patient is in critical danger.
The required action is admission to the ICU, continuous blood pressure monitoring, and administering IV meds like nicardipine, labetalol, or nitroprusside.
But the massive catch here: do not drop the blood pressure too fast.
Because of autoregulation. If you crash the pressure down to normal, the clamped cerebral vessels won't relax fast enough, causing an ischemic stroke.
The goal is a maximum 25% reduction in the first hour, then gently bring it down to 160/100 over the next 2 to 6 hours.
There are two exceptions, right? Aortic dissection targets less than 120, and preeclampsia targets less than 140 within the first hour.
Correct. Contrast that with a hypertensive urgency. High numbers, but a clinically stable patient with absolutely no target organ damage.
Often caused by extreme anxiety pain or non-adherence and rebound hypertension.
The action plan is restarting oral meds, close monitoring with vital signs every 15 to 30 minutes, and critically exploring the reasons for non-adherence.
Treating the root cause, not just the number. We have covered an immense landscape today.
We've gone from the plumbing mechanics of cardiac output to the complex pharmacological dances.
The vital role of the nurse in educating and empowering the patient. For nursing students, this isn't just a chapter to pass a test.
These are the exact tools you will use to prevent strokes and save kidneys every single day on the job.
I want to leave you with a final thought to mull over, building on everything we discussed. What happens in the near future when continuous cuffless blood pressure monitors become as common as smartwatches?
It's coming.
If a patient's wearable device could communicate directly with a microscopic implanted medication pump to adjust antihypertensive doses minute by minute based on real-time stress and activity, how would that fundamentally shift your role as a nurse?
You might move entirely from being an adherence enforcer to a lifestyle architect.
Focusing purely on the human behavioral elements of diet, stress, and joy, while technology manages the plumbing. It's something to think about as you step into the future of nursing. Thank you for joining us, and good luck with your Week 7 material.